Hey everybody, it's Friday. We're a little late, sorry, we had some technical issues with some of our equipment, but we're back in business with Plan B. Thanks to Casey. I'm Grace Stahlman, I'm your host. It's Friday, which means the Doctor's In Live with TOA is here and in the house with you today. As you can see, I've got a new guest today. This is Dr. Paul Crook. Dr. Crook joined us last year, and he's got some interesting stuff to talk about today that is really something that I'm not familiar with much at all, because again, I trained 25 years ago and technologies and things have changed so much that we would have killed to have this kind of technology when I was a resident. So it's exciting to talk about this new technology, or newer technology, that really has become part of the forefront of musculoskeletal care. As always, even though Dr. Crook and I are licensed physicians, remember, we're not your physician. We're not providing you information today that should be considered medical advice. This is strictly information, education, and a little bit of entertainment. So if you have a problem, if you have a musculoskeletal issue, go to TOA.com. You can learn about our services, you can learn about our offices, you can learn a little bit about our history. There's lots of information in the media center that's getting bigger and bigger and bigger every week with regard to topics of information, little insights from patients, insights from physicians. You can even make an appointment online, either in the office or via telemedicine even. We're still doing virtual visits for those people who can't travel or don't want to travel to the office, or particularly in this COVID-19 situation that we're dealing with. Before we get started, I'd like everybody to take just a moment to remember that today's 9/11. Hard to believe it was 19 years ago. I remember exactly what I was doing when we got notification of the Twin Towers getting attacked. I was literally operating with one of my partners at St. Thomas West Hospital, and it was an unbelievable time. I hope that even though 19 years have gone by and a lot of problems have surfaced in our country, that we can do what we did back then and come together and really start working together as a country again, rather than being divisive. That's the end of my politics. My hats go off to all those lives we lost on 9/11 and subsequently as a result, and let's move on. So again, this is Dr. Paul Crook. Dr. Crook is actually a Nashvilleian, kind of a rarity in Nashville, but I'm really happy to have him on board. We're going to do a little stuff with some computers, so I hope we can help you see this. It may be a little kind of haphazard, but we'll make it through. Anyway, Paul, thanks for coming by. Do me a favor, tell me a little bit about you, kind of what you'd like to know, your education, your background. I certainly don't want to presume I know anything about you that you don't want to know about, that people don't want to know about. So give me a little information.
Absolutely. So, so I'm Paul Crook. I'm one of the sports medicine specialists here at TOA. And like Dr. Stahlman said, I'm a native Nashvilleian. I grew up here and went to Montgomery Bell Academy for high school. I then went to Washington and Lee University for undergrad, where I was a chemistry major and actually swam all 4 years for college there. Then came back to Tennessee, where I went to medical school at the University of Tennessee in Memphis, and then traveled back to Virginia and did an orthopedic surgery residency at Virginia Commonwealth University. And then lastly, I went and did an extra year of training in sports medicine and cartilage restoration at Baylor College of Medicine. And there I was lucky enough to train with one of the world experts in cartilage restoration, Dr. Tom DiBerardino. And we'll be talking a little bit about that today, some of the newest techniques and advances in the field, and some of the tools we have available to us.
Awesome. So let's do a little, I always try to start with a little bit of an anatomy lesson. What's cartilage?
So cartilage is simply a tissue that's in every joint in the body. It's in your knees, it's in your shoulders, it's in your hips, and it's basically the white, shiny surface on the end of the bones. We'll bring this little model in right here. So it's basically this stuff right here. And basically it serves two essential purposes. One is it's a cushion for the bone. So it protects the bone when you're doing things such as running, jumping, going up and down stairs, that sort of thing. But the thing that makes it the most unique is that it basically provides a frictionless surface for which your joints to move. It's actually the most frictionless surface found in nature. It's slicker than a sheet of ice, and it basically allows you to have smooth, painless range of motion when you move any joint in your body.
And so, as I tell all my patients, it's the moving parts that tend to wear out. I would imagine because cartilage is the bearing surface, that's the thing that wears out primarily. Is that correct?
Yeah, that's correct. And you're born with a certain amount of cartilage, but that's really all you've got. Cartilage is also unique in that it doesn't have a very good blood supply. So as opposed to when you break a bone, where the body has the ability to heal itself, when you have a cartilage injury, the body has a very limited ability to actually heal itself. So basically how we describe it is, it sometimes looks like a pothole that you see on the street, and just like as a pothole sees more wear and tear and can get bigger and bigger, that same sort of phenomenon can happen in your cartilage. And once it gets big enough, it can actually turn into arthritis, which is kind of the end stage of cartilage defects, essentially.
Now, one little bit more of information anatomically. We're going to be talking about the bearing surface cartilage, or what's called articular cartilage. But there's also, in the knee at least, there's another cartilage that people talk about. I tore a cartilage in my knee. What's that?
So, there's several different types of cartilage. You have cartilage in your ear, you have cartilage in various different parts of your body, but the cartilage that we're going to be talking about is what we call hyaline cartilage or articular cartilage, and that's that smooth, perfectly frictionless surface that we were talking about.
As opposed to what I'm trying to get at is the meniscus cartilage, which people talk about. I tore cartilage in my knee, had surgery.
True.
That's a little bit different. That's a structure that is made out of collagen and such, but it acts more like a bushing between the shin bone and the thigh bone and allows motion to be more controlled in the knee. And that's a different topic.
That's true.
What we're talking about is the hyaline cartilage, the surface of the joint. And that's ultimately when somebody develops, as you said, when somebody develops arthritis, that's deterioration of that bearing surface.
That's correct.
So you mentioned that there's not really a good blood supply to cartilage. Does cartilage, can it regenerate? Can it grow? Can it heal? You said it couldn't really heal itself, but can it change over time?
Right. So this kind of will tell the story of what we've learned over cartilage for the past few decades. Initially, when cartilage is injured, it does try to heal itself, but it basically forms this substance called fibrocartilage, which is basically like the scar tissue of cartilage. It is a substance, it does provide some support, but patients typically still have pain and popping and clicking in their knee, and they still have problems with the knee. So it's kind of it's better than having nothing there, but your body is unable to provide the cartilage cells themselves to basically be able to heal itself.
Well, that's the basis of when I was in training. That's the limit of what we had, was we tried to do things to the joint to try to get the body to grow at least fibrocartilage, not cartilage itself. And there were limits to what it could really offer with regard to pain control and function improvement. So when I was in training, we basically learned cartilage can't heal. We to limp it along, but once you damage your cartilage, you're kind of in a pickle forever.
Yeah.
And fortunately, with the technologies you're going to start talking about, that's not always the case.
Yeah, that's correct. And we can actually bring in the laptop here so we can kind of show you a couple of pictures here.
I'll hold it. You can just look.
Okay. All right. So again, this is what we're talking about right here. So here's a cartilage defect. So it's typically a circular lesion that we'll see on the end of the bone right there. And like we said, it does have a hard time healing, but with some of these newer techniques that we're going to be talking about, we can turn this damaged bone and cartilage into a nice, perfectly smooth surface again. And ultimately, one of the things that this can help prevent is arthritis, because like what we talked about when that pothole gets bigger and bigger, eventually it becomes bone-on-bone arthritis, and that's when people start needing things like a partial or a total knee replacement. And that's one of the things that we're trying to avoid, obviously.
What's one of the more common ways that somebody can cause that kind of injury?
Yes.
Is there a specific mechanism, something they do?
Yeah, so there's basically two different ways that you can get a cartilage injury or a cartilage defect. And the most common way is actually through some sort of injury. So you may twist your knee, you may hyperextend your knee, you may have a fall, and basically it causes the bones to bang into each other and it may fleck off a piece of cartilage, and that's what causes that defect that again has a hard time healing. The other way is basically a wear and tear phenomenon. So you may have had a very minute injury 10 years ago and it creates a very tiny little spot or defect, and then the more that you walk and run and do whatever on that knee, that little cartilage defect gets a little bit bigger every time, and eventually it gets big enough to where it causes symptoms such as pain, swelling, popping and clicking, that sort of thing.
Like the pothole you talked
Exactly.
about. It gets bigger over the winter.
Right.
So. All right, next step.
Okay, so when you have a cartilage defect, you come in to see the doctor, you say, my knee hurts, I've been having some swelling. First thing we'll do is we'll typically get an x-ray, which fortunately typically is pretty normal. That means that you have not advanced to arthritis, but you're still having some symptoms. So typically a patient has tried taking some anti-inflammatories over the counter, may have tried modifying their activity, but eventually if none of those things work, then we end up getting an MRI, which this is kind of what we're looking at right here. So just to kind of compare, we're looking at the front of the knee right here, okay? So this area right here is the knee joint itself, and then we're going to focus in on this area right here. So that white color you see is basically bruised bone, okay? Bone should normally look this color right here. So this is the end of the femur, this is the top of the tibia or the shin bone. You see all this bone is very normal, but then you see where these arrows are, you have this white discoloration of the bone. And that to me tells me that not only is the cartilage damaged, but that really important bone underneath the cartilage is also damaged.
So this isn't necessarily a broken bone, it's really more of a bruise. And so when it looks like this, it's more of a recent type of injury?
Correct. It can be recent, or it can be, it may have lasted for up to a year or longer. But the important thing is that the bone itself is injured, and we'll get into the importance of whether just the cartilage is injured or whether and cartilage are injured as we go along. Cool. So again, we talked about this. Non-operative treatment is always the first step when you have a cartilage injury. About 80 to 90% of people can actually get improvement or even complete improvement in their symptoms just by doing things like taking anti-inflammatories, physical therapy, modifying their activity. So if we try those things, and typically anywhere from 6 weeks to 3 months is a good trial of non-operative treatment. If someone continues to have problems with their knee, that swelling or popping, even after trying some of the non-operative treatment, we may consider doing something called an arthroscopy or a knee scope. And basically this is a picture showing a typical knee scope. It's a very minimally invasive procedure where we are able to use a camera through one of the holes and instruments through one of the other holes to take a look at the inside of your knee and see if what we actually visualize corresponds to what we see on the MRI scan. Okay. So this picture right here basically shows a normal knee. This is what you would like your knee to look like, when the doctor looks inside. So you can see this is a very smooth surface. There are no holes in there. There's no defects. Same thing on this side. So this is the femur and this is the tibia. Both sides look completely smooth, and you have a nice normal meniscus in between.
That's that bushing we were talking about right here, that little shelf.
Exactly. Right? And that basically, the cartilage protects the bone, but the meniscus protects the cartilage. So it's kind of, you have a couple of different layers of protection in there. But this is a very normal looking knee.
And this little thing here is a little probe that we put inside the knee to feel around.
Mm-hmm. So this is what you would rather your knee not look like. So
the cue ball is gone.
Yes, yeah. So this is what we call a cartilage defect. So just like that MRI we were looking at, this is the area of the cartilage that has been worn away, whether it was from a wear and tear or whether it was a distinct injury. But the important thing to note in this picture is notice all the cartilage around this hole, essentially. And that cartilage looks normal. There's no defects in the surrounding cartilage. And that's one of the most important things regarding cartilage restoration, is that it needs to be an isolated defect. If you have, that's one of the things with chronic wear and tear, is sometimes it leads to what we call diffuse defects, where the entire surface of the bone is actually, the cartilage is injured there. So this would be an example of a focal or isolated defect, and this patient would be a good candidate for cartilage restoration.
Yeah, the pothole, but it's not I-440 where everything's worn out. So you need to have normal cartilage. You're trying to take away that hole and plug in a new piece of cartilage, essentially.
All right, so this, you probably can't read this, but this basically explains the same thing, that it requires a focal defect. And while we're talking about the indications for this procedure, one question I always get asked is, what age person can get restoration? And there's no direct answer to that. It's really more the status of the cartilage itself, not the age of the person. But typically, between ages 20 and 50 is kind of the most common age, where their cartilage may be injured, but they don't have bone-on-bone arthritis yet. And this can be a procedure that kind of restores their cartilage to normal and keeps them from progressing to arthritis. In your early 50s, you may still be a candidate, but as you get older and older, some of the ligaments and menisci and other structures of the knee start to wear out, and you become less and less of a candidate for this procedure. So typically between 20 and 50, but if you're very active and still run a lot and have not had any injuries in the past, early 50s to mid 50s even, it can be a reasonable option.
So if the pothole's there, good. If the street's worn out, not good.
Correct.
You can have a pothole with a worn out street. So.
Yeah. All right, so now we can go to the next one. Okay. So the first thing we're going to talk about is what's called an osteochondral graft. So like I said, there's two different categories. There's the category where the bone and the cartilage are damaged, like we saw in that MRI with the white color of the bone. And then there's the type where the bone is actually okay, but the cartilage is damaged. So the first category we're going to talk about is where the bone and the cartilage are damaged. And that's where this graft called an osteochondral graft comes in. Osteochondral is a medical term, but it's pretty simple. Osteo means bone. You may have heard of osteoarthritis or osteoporosis. So osteo means bone, and chondral means cartilage. So this is a graft that is made up of bone and cartilage that are connected. And typically, you can get osteochondral grafts from the patient's own knee. But there's only a very small area of cartilage that you can get a graft from, because obviously most of the cartilage you need for your own function. But so most of these osteochondral grafts come from people who donated their bodies to science, what we call allograft or cadaver graft. So obviously one question people always have is, is it safe to put, someone else's tissue in my body? And the good news is, yes, it's absolutely safe. These grafts are all tested for everything under the sun, for basically two different categories. One is to make sure that the cartilage from the cadaver graft is completely perfect. If they have any potholes or any problems at all with the cartilage itself, then it's not an acceptable graft. And then the other thing is to make sure it's a clean graft, make sure it's tested for all the different diseases and everything. So these are completely safe, clean grafts with normal cartilage that are FDA approved. So that's the first one that we're going to be talking about here. So this is a picture of basically how we harvest the graft. So again, we're trying to fill in that defect that we saw on the surgical images there. And so this is the graft right here. This is the cadaver graft. And this device right here is basically a stabilizing device. And you see this thing coming in from the top left. It is perfectly sized to the size of the defect that we're trying to fill in with normal bone and cartilage. So we're able to use a drill and basically core out a cylinder that perfectly matches the size of your defect. And so this is kind of what we're left with at the end. you can see the bone right here, and then the cartilage is right here. And that's perfectly normal bone and cartilage that's going to be used to replace your damaged bone and cartilage.
You do that in the operating room.
This is all
So
done.
all this is sterile.
This is all done in the operating
You
room.
measure the pothole, and then you create a plug for the pothole that fits that pothole. Is that essentially correct?
That's essentially it.
Cool.
So again, this is just another picture again of what we're trying to fill in. So we measure that perfectly, and then use the exact coring drill to fill in that defect. So this is like at the end. So this is the area of bone and cartilage that was damaged right there, and then you saw that graft from the previous picture, and it's perfectly sized to match that defect. And one of the new techniques that we're able to utilize now is a technique called press fit. So this is actually a post-operative x-ray of someone who had a cartilage graft or an osteochondral graft 6 weeks prior to this image. And you can see there's no screw or any metal at all. And if you look, you probably can't see the video, but right here you can see just a little bit of a whiter color of the bone right there. That's actually that cartilage graft. And so it is actually, even at 6 weeks, it is firmly healed into that bone, and that patient is able to bear weight with a painless knee at that point.
So basically, you're getting the bone to heal inside that plug, or the plug to heal inside that cylinder you created.
Correct.
Does the cartilage, in the back, in this picture here, you see the ring of where the graft cartilage is and the knee cartilage is. Does that ring heal in?
Yes.
Does it heal in with cartilage, or is it that fibrocartilage again?
So they've actually done studies on this, and it's a little bit of both. Okay. But the important thing is, we're seeing this very zoomed in. That is 1/10 of a millimeter. So that's a very, very tiny amount. It has a little bit of cartilage cells and a little bit of fibrocartilage, but that will definitely fill in. Exactly.
So about 6 weeks, you said. Wow.
Yep.
That's great.
All right, so this is a scary picture, I know. So this is the old way of doing it. So I kind of wanted to give comparing the old with the new. So this is the way that cartilage restoration was done in the 1990s and early 2000s. And as you can see, it's a pretty rough estimate. You don't have perfect congruence between the patient's own cartilage and the cartilage graft. And also you can see right here, it needed screws to hold everything in place. And it looks like one of those screws may even be pulling out a little bit. So long story short, this is the older way, bigger incisions, needed hardware, and we're miles past that point. At this day and age, we're able to do press fixation with no hardware. You don't have to have a screw removed at a later date. It's perfectly sized to that defect in your knee.
I take offense to old, because that was when I was in training. So I'll just put that proclamation out there.
And this basically is just an image of a healed incision. So like I said,
with the modern technique.
With the modern technique.
So you still have an incision. There's still an open wound.
There is still,
it's just not as drastic as
correct. It's still an open wound, but as you can see in this patient, very minimal scarring, and this is just about a month after surgery. So, awesome. All right. So that was bone and cartilage injury. And that's our typical way to fix a defect when the bone and cartilage are injured. Then the second type of injury is where the bone underneath is actually okay. When we look at that MRI, there's no bone bruising, and everything with the bone is normal. It's just that the cartilage itself is injured, and so we don't actually mess with the bone at all. What we do is this next technique called ACI. We can actually stay right there for a second.
Okay.
So ACI stands for Autologous Chondrocyte Implantation. Another big medical term, but we call it ACI for short. So autologous means from your own body. So the cells come from your own body. Chondrocyte means cartilage cell. And then implantation means that we're implanting your own cells back into your own body. So this picture right here, what we're looking at is the end of the femur bone, and we're looking at the cartilage. And there's 3 different zones of cartilage on the femur that are basically extra cartilage. These are areas of the cartilage on the femur that actually never contact the cartilage on the other side of the knee. And because of that, it's really cartilage that you don't need. We would never take cartilage from the center areas because that's where you're bearing weight. But on the edges over here, they actually never bear weight. And so that allows us an opportunity to, if you have, a cartilage defect and you failed all of the non-operative treatment, it allows us to go in with a very simple 10-15 minute procedure and take a little biopsy from one of these areas and get some of your own cartilage cells. The next step is we take those cartilage cells and we send them off to a lab where they're actually able to be expanded and multiplied into 10, 20 times cartilage cells that we harvest. And the idea is that those cartilage cells are then applied to a membrane that we can then go back at a later date and implant those your own cartilage cells back into your knee, into this area of the defect to get them to grow.
So this is a multi-stage process, and you're using biotechnologies to grow or multiply living cells to create more living cells of your own tissue.
Correct. This is your own tissue that we're using. So this is what we would do as the second stage. And let me back up. When we do the first procedure, when we take those cartilage cells, we also will measure the defect, and we'll also clean up any cartilage edges that are loose or flapping around that may cause pain and swelling and that sort of thing. So that will allow the patient potentially to have improvement just from that surgery alone. But the good thing about these cartilage cells is, one, you don't actually pay for the biopsy. The company that does this actually pays for the biopsy themselves, and you have a 5-year period of time where they will actually store your own cartilage cells to where if you have worsening of your symptoms in the future, like let's say you get 12 months of relief from the original debridement surgery where we kind of clean up the knee, but then you start to have pain a year later, that company still has your cartilage cells ready to go. And if and when your symptoms do come back, we have the ability to do this second stage where you have this defect right here, and then we take the graft of the cartilage cells and lay them into that defect to get them to heal.
How long typically, I'm sure it's a little bit different depending on how big of a surface area you need to create, but how long does it take for this company to take your cartilage cells and grow them to the quantity that you need to then repair the defect?
Right, so that's another area where technology has significantly improved over the past several years, and now they say about 5 or 6 weeks.
Okay.
So if you didn't get improvement from the biopsy surgery, the clean-out procedure, you don't really have to wait very long, to go ahead and do the cartilage.
So assuming you were planning to do that anyway, about 6 weeks ballpark turnaround.
Exactly.
Gotcha. Okay.
Exactly. Okay, and I think we're probably done with
Okay.
now. So we were just gonna, talk a little bit about recovery from the procedures. So both the osteochondral graft and the ACI procedure, there is a little bit of a recovery period. Those cells, when we initially put them in your body, they're not a part of your body yet. They need a little bit of time to mature and let your own body, kind of heal into them. So typically we keep people non-weight bearing or partial weight bearing for about 4 to 6 weeks. Okay, so that'll be crutches and a brace for about 4 to 6 weeks. But then after that point, you can fully bear weight, get back to running at about 3 months, and then if you're an athlete and want to get back to playing a sport, it's anywhere from 4 to 6 months, kind of depending on where the lesion was and various other factors. But most people are back living their normal lives at about 6 weeks and back to doing non-cutting activities such as running at about 3 months.
We talked a lot about this is mostly done in the knee, I would suspect. Is this done in other joints?
It can be. The shoulder and the ankle are the next two most common areas, and I would say if you look at all the joints together, probably about 90% of the procedures are done in the knee, probably about 5% in the shoulder and 5% in the ankle. So it can be done in other joints as well.
I'm just curious because I don't know any of this technology. The ACI procedure and the harvesting of your own cartilage, I would imagine there's not a whole lot of extra cartilage in the shoulder or the ankle to harvest.
That's true.
You have a little bit, because the knee joint is such a bigger joint. Can that be a problem? I mean, can you usually get the amount of cartilage you need to grow something like that in those other joints?
So that's a good question. So actually what you typically do in those situations is you still get the cartilage from the knee. So, if you do have a cartilage defect in your ankle or your shoulder, again, those are smaller joints, and there's not that free cartilage that we talked about in the knee. So you typically will, again, have that minimally invasive incision to harvest those cells from the knee.
And then lastly, are there any, other than, the worn out knee joint, the arthritic knee joint, are there any other contraindications medically, for example, smoking or whatever, that would keep people from being a candidate for this type of process? Any kind of medical problems or anything like that?
Yeah, so yes, like you said, smoking is definitely one of them. Anytime you have something that needs to heal in the body, blood supply is important, and smoking decreases the size of your blood vessels, less blood flow, less healing. There's a couple of other contraindications, such as inflammatory diseases such as rheumatoid arthritis, lupus, that sort of thing. And then obesity can be a contraindication as well. So, but yeah, other than that, there's really the main contraindication would be if you have that diffuse arthritis or diffuse cartilage changes in your knee. You really need to have that focal kind of defect, because that's the defect that we're able to treat. So
the last thing I wanted to briefly touch on is, in this day and age, everybody thinks there's a pill or an injection that can fix everything, and the buzzword, certainly in spine and other areas, is stem cells. Again, stem cells, we've talked a little bit about that in the past, which are cells in your body that basically have the potential of becoming any type of cell, depending on the chemical instructions that your body gives it. And that there is some interest in manipulating that in the laboratory to create things like cartilage. Is stem cell treatment anything related to this?
Yeah, that's a great question. And the answer is research is ongoing. So it's been determined to be safe. The question is whether it's actually effective. And some of that has been a little bit clouded because our results with these new techniques have become so much better that the stem cells, they've been tested at the same time, so we haven't really seen drastic differences between these procedures with a stem cell injection at the same time versus not a stem cell injection. So the real answer is, right now, I don't use stem cells for this procedure because I haven't seen any evidence in all the research that it significantly improves outcomes. But again, compared to where we were 15, 20 years ago, the outcomes have significantly improved. There were some recent studies that came out that looked at 10 and 20-year follow-up from these procedures, and at 10 years, it was greater than 95% patient satisfaction. And then the 20-year data is actually kind of looking at some of those old techniques, and it was about 75% satisfaction, but again, that was with some of those older techniques. So I think as we start to get 20-year follow-up on these newer procedures, I would think 85, 90% of patients would still be satisfied at that point.
And then one last question on the stem cells, because again, the jury's really still out with regard to whether they have a role in augmenting this type of treatment. Is stem cells by themselves to repair cartilage defects? Is there any data? There's a lot of claims of help, but is there any data at this point that suggests that stem cells alone can fix a cartilage pothole?
I wish we were there, because that would be easier than surgery, but but we're not quite there yet. There are hundreds, if not thousands, of studies looking at that exact question, but we're not quite there yet. But we are at the stage to where we can prevent the progression of arthritis and reverse it in some cases.
Yeah, I think that's the holy grail of most musculoskeletal care, is the injection or treatment that causes restoration without essentially no invasiveness or except minimal invasiveness, and it's really just not there yet.
Yeah,
so,
exactly.
Anyway, that's awesome. This was really interesting to me, because when I was in training, because I'm so old, again, we were just trying to create the fibrocartilage cap, the cover, by traumatizing the bone and such, not actually replacing the cartilage. And then there were people who started doing the cartilage transplants and things like that. So it's really exciting to see how things have evolved. And as things evolve, technology improves, and our ability to do things more precisely and more simply come about as well. Mm-hmm. So really, really interesting. So thank you. I appreciate you coming in. I hope this has been interesting to you guys. You can get a hold of Dr. Crook through TOA.com. Do you have any other contact information, a website, email, anything that you would want to give out to anybody?
You can access my website through TOA's website, okay. So just check out that website. Dr.
Paul Crook, again, he's one of our bright, shining stars, taking the place of us old, haggard people. And he's an awesome person, he's an awesome physician, and I'm really excited to have you on board because I think you're bringing the latest technologies to our practice that will really help TOA to move forward into the future. So I think that'll be it for this week. We're still trying to figure out what we want to do next week. However, I think the topic I'm going to choose next week will probably be just me. And I think what we'll do is we'll talk about my experience with the sacroiliac joint, which is the joint where your spine attaches to the pelvis, and kind of the latest techniques in trying to help people with sacroiliac joint pain problems to help them be more functional. So once again, if you have any questions, comments, please comment below. I tend to try to look at all the comments and answer the questions. We appreciate you following us. I certainly hope this is interesting to you. Again, if you have any topics that are of interest to you, please let us know. We've got a couple of topics in the works. Bunions and toe problems is one that really came up a little bit ago that we're still working on. We're still trying to get people involved other than just looking at this ugly mug to give you some information. And again, TOA.com, we can give you lots of information. There's lots of links to various topics, special interest stories in our media center. You can learn about our offices. You can learn about the new things that are happening with TOA in general. We've got some interesting merger topics going on with other groups in the community that will eventually make us the largest orthopedic practice in the state, if we're not already. So it's an exciting time for patient care with musculoskeletal problems. So TOA.com, again, you can make appointments online, you can make telemedicine appointments online, and go out there, have a good weekend, go out there, live your best life. We'll see you next week.